Welcome to EM Cases Rapid Reviews, where we review the take-home points from the EM Cases main episode podcasts so you can ace your exams and take stellar care of your patients.
Hello everyone, I'm Nick Claridge and welcome to another edition of Emergency Medicine Cases Rapid Review. I'm going to give you the information you need in order to effectively and safely manage patients with hyperkalemia. Hold on tight because this is going to be fast, informative, and to the point. This is what you're going to learn in this quick video. For starters, we're going to give you an approach to that potassium value that gets dropped in your lab. We're going to figure out what ECG changes are worrisome, and when you see that value, what should you be thinking about? Let's get started. You're on a busy shift. The department's full. Nobody's moving. You're seeing patients in the waiting room, ordering blood work, sending for x-rays, starting your treatment, doing what you do. When all of a sudden, a nurse hands you a panic result. A potassium of 6.3. You must have ordered that on a patient at some point, but you can't remember who or why. What do you do next? Let's start with the A, B, C's. But you already knew that. The guy's breathing and doesn't need CPR. What next? Hyperkalemia can be deadly, so we need to take precautions. Get him hooked up to a monitor, establish IV access, and get an ECG. If you remember anything from today, it's that hyper K equals ECG. What's that again? Hyper K equals ECG. This is going to be your decision point and form the basis of your approach. Okay, so the potassium volume's high. You look at the ECG. There are two options. One, the ECG looks okay. The patient is asymptomatic, like isn't complaining of GI or neurological symptoms. Then check to see if there's a potential explanation, like specific medications, obvious crush injury, or buddy's on dialysis, which was due yesterday, but decided to watch the hockey game instead. If nothing's piquing your suspicion, repeat the sample and sit tight. You're already set up. Patient's on a monitor, you've got IV access, and your ECG is normal. Jump back out into that waiting room and keep plugging away. But if the ECG is wonky, then that's a different story, and that's what we're going to show you next. So now that we know the ECG changes are pivotal to our approach, what are those changes? Hyper K is known as the great imitator. All ECG changes you see are not specific to the disorder of hyperkalemia, they just mimic a primary electrical problem. So it can pretty much imitate anything. But to help you out, there are a few things that you should keep in mind. 1. Patients with profound bradycardia, especially in the setting where pacing isn't working. 2. Slow ventricular tachycardias, less than 100 beats per minute with no P waves. And 3, really wide complex tachycardias where the QRS is greater than one large box. These could all be hyperkalemia. Now, there are also some classical appearances of the ECGs you guys are probably all familiar with, but let's go through them. The first is tall tented T waves. You can see here that they're taller than the R wave of the QRS complex, and they usually occur at serum potassium values of 5.5 to 6.5. You may also be looking at this and thinking, couldn't these be the hyperacute T waves of an early MI? And I'll quickly show you the difference. In early MIs, the T waves are broad-based and rounded, compared to those of hyperkalemia that are narrow-based, tall, and pointy. You can see the difference here. Just remember, if you're concerned, get serial ECGs. You might either see a progression of the MI into ST elevation or progression of the hyper K. I like to think about the other changes by the area of the heart the potassium affects, starting from the top, moving to the bottom. With potassium values of 6.5 to 7.5, the atria are affected. We all know the electrical activity of the atria is represented by the P wave. In this ECG, the P waves are difficult to visualize. So let's get a closer look. You can just make out the P waves. The effect of the hyper K is to flatten these P waves or make them disappear. And you can also get prolongation of the PR interval. As we move to the ventricles, the QRS widens. But let's get a closer look as well. Here you can see the QRS is wide and looks asymmetrical. It's asymmetrical because the S wave sags as it approaches the T waves. This is what you don't want to see. This is the pre-terminal rhythm of hyper K, the dreaded sine wave pattern. If the hyper K goes unchecked, the QRS and T wave merge to produce this, and this can lead to VF. That was a lot of information. Let's do a quick recap. We've got hyper K. Let's get the ECG and check it. If the ECG has changes, as we just discussed, then we need to initiate treatment. But don't worry, I'll outline that in part 2. If there are no changes, then we're okay. But we need to check for concerning symptoms or determine a potential cause. So, what are those causes? I'm going to make this really simple. There are essentially 5 causes you have to think about. Most people remember medications and kidney failure, but you should also keep in mind massive cell death and conditions that cause acidosis. You might be asking me why there are only 4 pictures on the screen and I've told you about 5 causes. Well, that's because one of our causes is actually hidden. And that's because the potassium is actually not high at all. This is called pseudo-hyperkalemia. For its causes, it's easy to remember hemolysis because the lab usually lets us know. But I always forget derangements of platelets and white blood cells, so keep that in mind. Starting with medications, we can all remember the ACE inhibitors, beta blockers, plus those potassium-sparing diuretics. Stuff you may not remember are something that everyone takes, like NSAIDs and Septra. You've also got people who are just adding potassium to their diet. This one's more obvious, patients with pre-existing renal insufficiency. But remember, the patient doesn't need to be on dialysis to develop Hyper-K. How do we get massive cell death? Well, we can break those up into patients who have had something externally done to them, like being crushed or really badly burned. Then you've got those patients who have been given something internally, like recent chemotherapy causing rapid cell turnover, and those who have had massive transfusions. The last of the big 5 are conditions that cause acidosis, the most common being DKA, but also think about primary adrenal insufficiency. Alright, so there you have it, a quick introduction to Hyper-K. Let's quickly go through some of those take-home points. Hyper-K, think ECG. Think about the ECG changes in relation to the atria and ventricles, and the big 5 causes, remembering pseudo-hyperkalemia. Thank you all for listening, and see you again for part 2, where we're looking at the management of Hyper-K.